afterwards, so successful embolization, the patient's in-house for a couple of days, and then you do a repeat CT scan. Can you give me a sense of like how much streak it causes on like a post-embolization CT?
Yeah, there's going to be some artifact.
Yeah.
When you compare lava to onyx, lava has about 29% less tantalum. So the artifact is a little less than maybe you're used to seeing with onyx. You're certainly going to see some streak artifact with coils as well, but it doesn't preclude a diagnostic CT scan. You're going to know if there's bleeding despite the presence of this material there. And so I think some of the newer products, whether it's a conformable embolic like Obsidio or lava, the artifact is, I think, tolerable is what I would say when it comes to diagnostic CT scanning.
Going back to the setting of trauma, ballpark, what's the biggest vessel you can use it in? Hold on, here's another question, because I just want to throw 100 questions at you and see how good you can do. Can you inject it through your parent catheter, like a 5 or 6 French catheter?
I would not. I think you're
Okay.
dealing with a lot of volume, and you're also jeopardizing all your work that you did to get that parent catheter where it needed to go. So even if it's pretty straightforward, I still prefer working through a microcatheter just in case something happens with the catheter. I want to just be able to pull it out and replace it. So I would not recommend putting it through an 035 ID catheter. I think it's going to take a lot more embolic, and you run into a greater potential for problems with that.
So biggest vessel potentially you can use it in?
I mean, we've done very large pseudoaneurysms
Okay.
that, could be upwards of, 2+ centimeters. So it can be used in a lot. In those cases, what I'll usually do is put a couple of coils in there to frame out the aneurysm so I have some sense of where it's at, and then just use the liquid to fill the spaces there. That's obviously a very rare case, right? That's not the norm. I would personally say that I try not to use it as a primary agent in vessels that are larger than 5 or 6 millimeters in diameter. What I worry about is the flow carrying it further than I want it to go. So if I'm in a large vessel and for whatever reason I want to use a liquid, I'll usually use a backstop of coils or a plug and then use it to fill space behind that backstop. But I think as a primary agent, it's better in some of the smaller vessels.
And no problem as far as like compatibility, where if you want to do a backstop of coils or a plug, filling the void with glue. And I guess there's no need to bookend it. Well,
No, I wouldn't. First of all, bookending is just going to complicate it because you're not going to want to put it through the delivery catheter. But I would say not only is there no problem, I would actually recommend it, especially for a new user of a liquid like lava. In fact, I think it will make the average person feel a bit more confident that they're going to avoid things like non-target embolization, that it's not going to run away from them distally. So if you put, let's say, 2 coils, they can even be pushable coils, just something that will create that backstop. For example, let's imagine the very bottom of the GDA in an upper GI bleeder. Put a couple of coils right at that bifurcation at the terminal portion of the GDA. And now if you separate your catheter maybe by just a few millimeters, you'll fill that space. The coils will catch the liquid. It's very rare for it to go through. And you'll be able to watch it come back along the course of your catheter. And then all you really have to do is figure out when to stop. All right, that's the biggest task you'll have.
so thinking about like some high flow states that maybe you want to avoid, I was thinking also in the setting of peripheral hemorrhage, like you get into, I don't know, a bleed and it turns out to be an AV fistula. Maybe not a good case for.
I don't think I would recommend that unless it was very distal
Mhm.
and you felt like you would have enough space before the fistula to fill that feeding artery. But I think let's just take a step back. The one thing you want to avoid is the liquid going somewhere you're not planning for it to go. So obviously, if you're in a high flow AV fistula, the big worry is that there's going to be a lot of flow directed towards the fistula. It's just going to carry the liquid right through the venous side, and then God knows where it's going to go. So to me, that would be something I would avoid unless, for example, I was able to get my catheter all the way out there into the fistula itself or just before, fill that space with coils as a backstop, and then very slowly administer a more viscous liquid that the coils will catch. But I don't think I would use it as a primary embolic product. So, not only is it traumatic AV fistula, but, don't use it for pulmonary AVMs. Kind of a similar idea, right? You just don't want it to go someplace that you can't control. That has significant implications.